Hey, welcome everyone to our Thursday IFAM seminar series. My name is Kelly Michelson. I am the director for the Center for Bioethics and Medical Humanities, which is part of IFAM. And I'm really excited to introduce our speaker today. Before I do that though, I just want to go over a couple of quick housekeeping things. The first is to say that if you have a question during the course of the talk, please enter your questions into the Q&A button and not into the chat, because we're not going to be monitoring the chat, but we will be taking questions in the Q&A. So if you could put your questions there. And the other thing I wanted to say before we get started is to remind people that these seminars happen every Thursday at noon. And next Thursday, we will be holding a seminar entitled Supporting the Critical Role of Community Organizations During COVID. And there'll be a panel of community partners. So I want to encourage everyone to participate in that discussion as well. So I am thrilled to introduce Dr. Paquette today. People talk about the triple threat in academics, and Dr. Paquette sort of has her own version of the triple threat. For many people, that's incredible success in clinical education and scholarly work. Well, Dr. Paquette has all those and more. In addition to being a physician, she has a law degree and is a bioethicist, and she is incredibly active in all of those areas. She received her master's degree at Northwestern and then went on to receive a medical degree, law degree, and master's in bioethics at University of Pennsylvania. We were thrilled in 2013 when Erin joined the faculty here at Northwestern in the Department of Pediatrics, where she is a pediatric intensivist in the Division of Critical Care Medicine. Erin's work focuses on research, advocacy, and policy development that reduces health disparities, addresses bias, racism, and other structural determinants of health. She is passionately dedicated to promoting social justice. Dr. Paquette's work evaluates the use of medical legal partnerships to address social determinants of health, and as well as understanding public perceptions of brain death. But the topic that she'll be talking about today relates to her work in evaluating disparities in research enrollment and participation. And for that work, she's supported by the National Institutes of Health. So without further ado, Dr. Paquette.
Thank you, Kelly, for that overly generous introduction, and to IFAM for allowing me to come and talk a little bit about my work and a little bit about my thoughts about disparities in research enrollment, as well as how they have implications for public health emergencies. I might have bit off a little bit more than I could chew in a 1-hour talk on this, but I'm going to try to take you through some of how I think about these issues and would welcome conversation and discussion. In terms of disclosures, Kelly already sort of outlined my funding disclosures. I don't have any conflicts of interest. I do want to make a general disclaimer, however, just in trying to be thoughtful myself in how I use language. I want to point out that references to diversity or lack of diversity by race are a function of the data that's available with respect to research. But I recognize, and I'd like us all to recognize, that race is a social construct, and the differences that are seen are either the result of systemic racism or other social conditions that are associated with race. And race acts as a proxy for them, but is not in and of itself a determinant of most of the findings that we see. I also am both honored and humbled to be giving this talk during Black History Month. And I wanted to start by just recalling some of the most memorable words to me of Martin Luther King Jr., who spoke in a Chicago address on healthcare these words: "Of all the forms of inequality, injustice in health is the most shocking and inhuman." And he gave us a call to action in that delivery, as he did many times. And I keep that in mind in all of the work that I do, and I hope that we will as we talk through some of these issues today. I also think that it's important to situate ourselves in the context of the history of medical abuses, particularly against Black individuals throughout our history as a country, and globally, really. But starting in the 1850s, or at least tracing back to the 1850s with medical procedures, repairing prolapsed uteri and learning how to perform those procedures on Black slaves without anesthesia, moving to the 1930s and 40s with forced sterilization of African Aryan children. And the 1950s was when the HeLa cell line was created. And I'm sure most of you are familiar with the story of Henrietta Lacks and the use of that cell line really to further not only cancer research where it originated, but really many, many different forms of research without recognition or consent, which has stirred a number of conversations about the ethics of that activity. In the 1960s, there were the Singer radiation exposure experiments where individuals were exposed to differing doses of radiation without full informed consent, some of which led to the death of some individuals. To the 1970s, where there were stereotypical perspectives that led to a study at Hopkins trying to identify genetic predisposition to crime. The 1970s was also when the Tuskegee syphilis study ended, which I'm sure most of you are familiar with, in which individuals were exposed to syphilis to follow the natural history of the disease without being given treatment after it was, even after it was available. The 1970s also brought the Belmont Report, which was one of the foundational documents of research ethics, outlining 3 principles: respect for persons, beneficence, and justice as foundational to research with human subjects. Despite the Belmont Report in the 1970s and recognition of a history that is really tainted with a number of abuses against the Black population, in the 1990s, we still saw, and we continue to see some research that calls into question our commitment to eliminating such violations. In the 1990s, there was a new measles vaccine that was tested without consent on infants that were largely comprised of Black and Hispanic descent, and also a study that was looking at juvenile records, but specifically excluded white individuals. And so I think this just serves as a reminder to me that there continues to be work to be done. I outlined that the Belmont Report highlighted 3 principles foundational to research, which include respect for autonomy or respect for persons that we often see play out in the concept of informed consent, the concept of beneficence, or trying to minimize burdens and maximize benefit and to avoid harm to individuals. And then this principle of justice. And I think we oftentimes in individual research think more about the first 2 principles, but justice is a critical ethical concept that underlies research. It refers to the distribution of benefits and burdens and ensuring that there is a fair distribution of those. It is a question of whether there needs to be an equal distribution of burdens and benefits, and I'll raise that in the talk subsequently. But I want to point out that the Belmont Report anticipated and articulated different conceptions of justice, some of which allowed for varying distribution of benefits and burdens according to need, effort, or contribution. And I also want to highlight that the Rawlsian difference principle, so John Rawls, who articulated theories of justice, the difference principle outlines that there can be inequality in distribution of goods within a society, and that's justified as long as inequalities favor the least well off. And so I think it would be helpful to keep these concepts of justice in mind as we think about disparities in the research arena. So why is inadequate representation problematic? Well, really it threatens study feasibility, validity, and generalizability. From the feasibility standpoint, it can lead to premature study termination. If the research is not encompassing of a broad enough population, the study findings may not be applicable, and so validity and generalizability can be called into question. And then there may be an unfair distribution of benefits and burdens, potentially leading to exploitation of some groups who could be overrepresented in risky research, or lack of benefit for those who might be underrepresented, for whom we won't know the research outcomes. When we look at studies in the adult population, they demonstrate consistently under-enrollment in clinical trials. So this graph here just shows the small percentage of Black, American Indian, Asian, and Hispanic individuals that make up this small bit of this pie chart compared to the white population. And this is despite the fact that in these trials that were conducted, when outcomes were looked at by race, there were some differences associated with pharmacokinetics of drugs, efficacy, and safety that were associated with race. Now, I'll remind you that these are not necessarily reflective of biological differences, but could be reflective of, say, epigenetic differences related to environment or exposure of individuals for which race acts as the proxy. But the point is that there may be differential responses by race, and we fail to understand those fully if we're not adequately representing those populations in research. Even potentially more problematic is that as we move to thinking about precision medicine approaches or individualized health approaches, there is a profound lack of diversity in genomic studies, and this has been repeated by a few groups over different time points. On the left side here, one study you can see showing European versus Asian versus other underrepresented groups, huge discrepancies between participation, irrespective of the study type. When another study looked at rates of enrollment of different groups from 2009 to 2016, the light blue bar, at the top represents the white European population. Asian ancestry is in the, African ancestry is in the dark blue bar below that. Those of mixed ancestry is in this tan bar, Hispanic, Latino in the yellow. And then Pacific Islander, Arab, and Middle Eastern, and Indigenous individuals. And you can see that between 2009 and 2016, we really still largely see mostly European ancestry, and then the Asian population increasing in participation, as well as some increase in the African population. But still, these make up a discrepant minority of groups that are participating in genomic research. So from that data, I want to keep in mind that diverse adults are underrepresented in clinical trials as well as genomic research. In some of the work that I've done, we've sought to understand how do these disparities play out or not play out in the pediatric population. So in this study in particular, we examined participation in a biorepository characterizing participation of approximately 3,000 children. For this study, each parent had an opportunity to participate via an opt-in consent form at the time of their child's admission to the PICU. The y-axis shows the odds of missed enrollment by race, that's plotted on the x-axis. And we characterized missed enrollment either because they failed to return the opt-in form or they refused consent on the form. So this slide shows missed enrollment due to incomplete consent. And you can see that every group that is not non-Hispanic white has a higher odds of missed enrollment due to an incomplete consent. This was consistent when we looked at consent refusals, that there were higher rates of consent refusals throughout all groups that were not non-Hispanic white. So in conclusion from this is that diverse children appear to be underrepresented in biorepository or genetic-based research. In some of my other work, I've looked to characterize the participation of diverse children and parents more generally across pediatric research. And to do this, we retrospectively assessed participation across studies in the PCARN, the Pediatric Emergency Care Research Network, and CAPCORN, which is a Pediatric Critical Care Research Network, with studies that ran across a spectrum of differential designs, both interventional and observational studies, as well as different consent requirements for participation. Just to provide a little bit of context for the data that I'm going to show, as well as for us to think about how we reflect participation in research generally, I want to highlight how we thought about participation in these studies. So we defined participation in the study by a participation proportion, which is the number of individuals enrolled in the study divided by the denominator, or the total population that we could assess for the denominator. This graphic to the right of the slide shows you all the various ways that you can conceptualize a denominator of individuals. So some studies looking at participation in research have characterized that denominator population by census, comparing study populations to rates of that race in the general population. You could compare it to the general population at institutions, in our case, pediatric institutions, the general population of those pediatric institutions that were part of the research network, and then the research network institutions restricted by whatever was being studied, so the diagnosis of interest in the study. You would, if we had the data, you would want to look at the population specifically at study institutions by diagnosis, and then specifically those who met eligibility criteria. And you can imagine that depending on the denominator you use, you might get different rates of participation and make different conclusions. So I think it's important to keep in mind when we're consuming data, thinking about participation, that we know how was that assessed within the study. In the data that I'll show you, we had available to us the general population at network institutions using data registries for that research network. And then we were able to restrict those by diagnosis. So you can see we're somewhere in the middle of the best estimate of the denominator that we would want to get to. So what we did to get our denominator data is we used two different methods. The institution-based method looked at the general population within research network institutions. So these were all comers, not necessarily those who had a diagnosis of interest in the study. And these were using the PCARN core data project and the CAPCORN core data projects. And then we did it by a disease prevalence method, where we used the core data projects, but restricted them by ICD-9 code that matched to whatever was being used in the study for those studies that we were able to identify ICD-9 codes. For each study, what we did was we looked at the rates of participation in the study, the distribution of races by study population, and then the distribution of races by core data project. So to orient you to this slide, on the y-axis is race, on the x-axis is the participation proportion. The black bars show the study participation, and the hatched bars show the participation or the rates in the core data registry. To assess for differences, we used a chi-squared goodness of fit for differences in distribution between these populations. And for all the populations, there were significant differences in distribution between the study institutions and the research studies themselves. In this particular study, you can see that non-Hispanic white and Hispanic children were overrepresented, while non-Hispanic Black children were underrepresented. These findings were consistent when we restricted this to disease-specific, the disease prevalence method, where Hispanic and non-Hispanic white were overrepresented and Blacks continued to be underrepresented. So we did this across all those studies that I outlined in the original chart, so 9 studies that varied by study design as well as consent mechanism. Here, what we did to summarize the data is we took the difference between the percentage of each race in the study and the percentage of the denominator of interest to obtain either a positive or negative deflection from 0, where positive deflection above the line represents overrepresentation in the study, and a negative deflection below the line reflects underrepresentation. And what you can take generally from this chart, and I'll point out some specifics on the next few slides, is that there are both bars above and below the line. So there's both over and underrepresentation. So this graph shows or just points out that non-Hispanic Blacks both have under and overrepresentation using institution-based data. Non-Hispanic whites are mostly overrepresented, and Hispanics are both over and underrepresented. We were able for 3 studies to get ICD-9 codes that allowed us to restrict the denominator by disease of interest. Here we found that non-Hispanic whites remained overrepresented using the disease prevalence method. Non-Hispanic Blacks were largely underrepresented by this method, and Hispanics appeared to be overrepresented. So what we can conclude from this data generally is that diverse children are both under and overrepresented in clinical research. In another study, we've sought to understand the factors that might impact retention of these children when they do, or parents when they do enter a study. So this chart shows you data from one study that enrolled parents in a navigator-based study, where a navigator was used for communication within the PICU compared to general standard of care and a brochure describing different components of the PICU experience and resources. And we sought to understand whether individuals who were asked in the study to complete surveys at various time points, including during their admission, at discharge 3 to 5 weeks and 3 to 5 months, we sought to understand which factors would impact retention or return of study materials at different time points in the study. The chart reflects the percentage of individuals by different sociodemographic characteristics that return study materials at various time points. And I'm showing you here the factors that we found that were statistically significant. So at the time of research approach, despite there being materials and study staff that spoke English and Spanish individuals were less likely to be approached. At discharge, being of people of Hispanic ethnicity were less likely to return surveys. This was true also at 3 to 5 weeks and 3 to 5 months. We found that at discharge and at 3 to 5 weeks, families with multiple children were less likely to return surveys. At 3 to 5 weeks, those with lower education, when no college was compared to college or above, those with less education were less likely to return surveys. Those of, and then at 3 to 5 months, those of lower income, and then those of non-white race ethnicity and non-Asian race ethnicity were less likely to return surveys. So anybody who was in the Black or other population. We found that being female or having a partner increased your rates of survey return at both 3 to 5 weeks and 3 to 5 months. And one general feature to take from this is that as you move farther away from the time at which the study team is there approaching you and you're in a more controlled environment in the hospital, the less likely you are to participate in the research, and the more it seems social factors are at play the further out that you get. So I take from this that retention barriers may build and may be different from those barriers that are present at the time of recruitment and enrollment. So I think the next question to ask is, well, what do you do about all of this? And a lot of work has been done in the adult population that we're hoping to build on in the pediatric population. But I think one of the steps forward is to try to understand what study factors or participant factors are related to differential participation, and what strategies might be more useful for certain groups than others. So I'm going to share a little bit from our data and then some general information on strategies and thoughts about that. So in these next couple of slides, what I'm showing you is how the mechanism of consent was related to participation by different racial ethnic groups within the network studies that we looked at. So here, the top 2 rows represent formal consent or assent mechanisms, where the bottom 2 rows represent informal consent and assent mechanisms. And you can see that when you compare Black versus white participation, participants in studies with formal consent mechanisms had a lower odds of being non-Hispanic Black compared to white, while those with informal mechanisms had a higher odds of being non-Hispanic Black compared to white. We hypothesize this may relate to issues related to trust, and I'm going to speak a lot about trust or a bit more about trust subsequently, but we suspect this could be related to trust, and that those issues may be more triggered by a formal process rather than an informal process. Meanwhile, when you look at individuals of either Hispanic or other race, ethnicity, these have there are higher odds of being these Hispanic or other race, ethnicity compared to white in studies where there are formal consent mechanisms, and lower odds in studies with informal mechanisms, including verbal consent. We suspect that some of this may be related to language being the primary, or spoken language being the primary mode in these other consent mechanisms. Although we don't have that data available to us to investigate that further. But basically, I think those two slides show that differential participation can be related to consent mechanism. This study looked at whether differential participation was related to different recruitment strategies in seeking to understand which recruitment strategies might be most effective by various sociodemographic characteristics. I think for many of you, this slide may be, the text on this slide may be small to look at, but what I really want to highlight about it, and that I'm hoping that you can see, is that there are scattered gray and white boxes throughout the slide by most of the sociodemographic variables. The gray boxes you may or may not be able to see have little pluses in them, and these reflect strategies that were positively associated with recruitment, so had higher recruitment effectiveness using these strategies in those sociodemographic groups, while the white boxes reflect strategies that had lower rates of success. And what I'd really like to point out is that there's not a uniform strategy really that applies as effective to any particular group or different different sociodemographic characteristics. And I think that what all of this tells us is that different recruitment and consent strategies may be effective for different diverse populations. So the 5 conclusions kind of above are all leading to a motivation to understand more about decision-making related to enrollment and retention in studies, inclusive of both clinical trials, genomic research, but also more broadly. To guide this work in what I've been doing, we've developed a logic model based on our understanding of decision-making, in which there are multiple influencers in the decision-making process, showed in this yellow circle, surrounded by multiple drivers of participation, and then discrete factors that are attributable to the different drivers. Just pulling out one of the influencers and highlighting the different drivers and the different factors, you can see that there are such a multitude of avenues in which there might be a place to impact or not participation. And it really demonstrates the complexity of this decision-making process that we often ask people to make in very short timeframes. That becomes particularly relevant when you're asking people about research or other activities in the public health emergency setting. And so I want to just, I want to keep in mind the complexity of this process as we think about ways to address differential participation. Equally important is recognition, as I've tried to point out, that at various time points in the process, different factors may be at play. So this slide highlights that recruitment science really has to consider the spectrum of engagement, and that this begins not just with the traditional consent process that we think about from approaching and consenting individuals, but really from the formation of our research questions to how we identify the populations of interest to study, then approaching them, obtaining consent, getting enrollment and retention in the study, and that we really need to think about strategies at each of these time points, whether they're effective or not, and in particular, whether they're responsive to the needs for looking at research from an equity lens. So really, I think about reducing disparities in engagement and promoting proportional participation of diverse groups as really as strategies to ultimately attain equity. This slide may be familiar to many of you or something similar to it, outlining the differences between related but distinct concepts when talking about disparities and talking about equity. And so I just want to quickly go through the differences between these concepts, and I'll come back to some of them. So inequality is the notion of unequal access to opportunity. So here we can see that some individuals are privileged. This individual on the left is privileged, having the tree bend to their direction and the apples just fall down, while the individual to the right, there are less apples present and the tree is bending away, not favoring the apples falling down. And that leads to a state of inequality that's set up by a barrier that exists outside of any tools or implements that you may use to try to help the individual. Equality relates to the idea of even distribution of tools and assistance. So here you can see, okay, well, we'll give everybody a ladder to make it easier to reach the tree. But the ladder for the person standing on the side where the tree leans away doesn't help that individual get close enough to actually get the outcome of getting an apple. Equity refers to utilizing tools and customizing them in a way that identifies and addresses inequality. So here, because the tree leans to the left, giving a taller ladder to the individual standing on the right to help them get to the same outcome. And then thinking more broadly, the concept of justice is fixing the system to offer equal access to both tools and opportunities. So here, finding a way to stent the tree and pull it back in the other direction to give an equal opportunity in terms of access, and then providing equivalent tools to get to that outcome. Adjusting tools is oftentimes where research teams have opportunity. And so this is where I think a lot of work that is done focuses on achieving equity, although there are some broader concepts of justice that we'll get to as well. In order to think about what we can adjust to achieve equity, we have to understand more about the reasons for lack of diversity. I've highlighted that we are continuing to study this in the pediatric population. And I think while this has been studied extensively in the adult population, there still is work to be done and things to be clarified. But we know that there are some reasons associated with lack of diversity that include poor awareness of opportunities to become involved in research, mistrust of research, and the healthcare system, which I've outlined as it's been stated, although as I'll speak to later, rather than thinking about mistrust, I think we need to think about breaches of trust and trustworthiness. Confusion and concern about research, transportation barriers, the study criteria themselves, lack of clear language and study materials, fear about the research or receiving placebo, concerns about health coverage for any health needs that may arise as a result of participating, lack of diverse study staff, and feeling that the value of participation is not high enough. When I begin to think about how do we implement principles of equity into responding to these reasons for lack of diversity, one framework that's come to mind is thinking about how many studies have moved to adaptive trial design. So rather than utilizing a fixed sample design in which you have a study design, you conduct your study according to that design, irrespective of what any interim analyses or what your enrollment or anything is showing, and then you go to analysis at the end of the study. Adaptive designs during the conduct of the study allow for review and then adaptation of approaches wherever they're necessary to meet study goals and then move forward to analysis. I think we can think about, or we've started to propose and think about the concept of adaptive engagement as an analogous way to implement an equity lens throughout the research process. So again, recall that this will require attention to the entire spectrum of engagement from the formation of a research question. And when you put an adaptive process onto this, it starts to look complicated, but necessary. So really at each stage of the process, the potential for customization has to be considered with adjustment of the engagement or recruitment approach at that time point to meet the needs of ensuring proportionate participation by diverse groups, or to meet the ultimate goal of having that in the research study. And I'll walk through each of these with examples of the kinds of questions we might ask or think about as we're implementing such an approach. So from the standpoint of the research question, asking, is the research question responsive to both community and researcher needs? So from the formation of the question, really involving voices and perspectives of the community, and potentially altering, customizing, or adding onto the research question something that will provide outcomes that is useful to the community or population of interest in addition to the researcher's outlined goals. Thinking about whether at the population stage, the design of the study and the recruitment plan risks excluding disparities populations. And this will also come into play in the approach. So at the timing of or at the point of approach, thinking about the hours in which recruitment is happening, the locations in which it's happening, primary language of recruiters, and the preferences that may exist for differential preferences for information delivery, whether individuals prefer to receive information verbally from a study team member, written materials, use of arts to create audiovisual materials has been successful, and potentially doing assessment and using variable methods within the same study to meet the needs of the individuals that you're attempting to recruit. And then continuous attention to altering all of these features or factors as the study continues in order to meet enrollment targets that are proportional. From the standpoint of consent and assent, considering measuring health and research literacy as part of the process of engaging and enrolling individuals, and an assessment of their understanding of the study in particular, and then using feedback mechanisms, having variable educational tools available to correct misconceptions to ensure that there is really fully transparent and full, complete information given at the time of consent and assent, and recognition that this process is continuous and may need to be repeated periodically throughout the conduct of the research, that it's not a single point in time process. In terms of enrollment, thinking about whether differential compensation, reimbursement, or incentives should be offered even within the same study. I think from the standpoint of IRBs and the research ethics community generally, this may be an ethically controversial concept, though there has been exploration that it can be ethically justified and permissible to differentiate payments in the same study based on the conditions that exist. So from the standpoint of reimbursement, obviously this may differ because that's going to be based on costs that are actually incurred by the participant. Compensation might be justifiably different based on local wages or cost of living considerations, but also based on differential time and effort that may be required by some participants over others, or by unique contributions that individuals can make to research studies. And then incentives, which really are in a separate and discretionary category compared to reimbursement and compensation in research. But still, it may be justified to differentiate incentives to individuals to try to get higher participation, for example, from groups for whom participation is important for scientific validity or social value of research, and there's lack of participation of that group. I think, however, implementing differential payment the way that we currently evaluate providing payment in research studies will require some open-mindedness and sort of different thinking in terms of concepts of justice on the part of institutional review boards in weighing justice considerations potentially more broadly than individual and equally to individual considerations when reviewing research studies. And then at the time of thinking about different things, different points of retention, thinking specifically about potentially needing to offer reimbursement for childcare, since that seems to be an issue that came up continually at various time points, at least in our work. The use of trusted or credible messengers to encourage continued participation in research, and then considering the concept of graduated payments, that one's burdens may increase. You know, we saw in that chart that there were more factors at play the further out that you got that created barriers and burdens to participation, and that offering additional ways to compensate for these burdens or to overcome them might lead to improved retention for groups that are particularly susceptible or vulnerable to those burdens. So we are continuing to think about and develop the strategy of adaptive engagement as a model for injecting equity considerations throughout the recruitment process, and currently mapping these ideas onto the different conceptions of justice. However, to get to those concepts of justice, which I do want to address a bit today, I want to take a few moments to think about these ideas in the context of public health emergencies. So just to go through a couple of principles that underlie public health emergencies. Often data-driven responses are necessary, and these require accurate and complete information reflective of the population, the full population impacted by the public health emergency. Implementation of measures at a population level might be necessary, and these could disproportionately impact segments of the population from the standpoint of surveillance, prevention, and evaluation of interventions to mitigate an emergency. Oftentimes in implementing these different public health strategies, we might find that underlying structural barriers to equity are exacerbated. However, despite knowing that these barriers exist, cooperation from those disproportionately impacted is needed in order to have a full public health response. And in this context, I've mentioned the notion of justice and distribution of benefits and burdens, but also what comes to the forefront is the concept of solidarity, or the notion of belonging to a community and having a responsibility to work to promote the good of that community. And this rises as a dominant value in the public health setting. Again, some of these graphs, I suspect many of you have seen. We're all aware of the disparities in coronavirus throughout the Chicagoland area. This graph, or this map rather, shows COVID cases by zip code. These are earlier in the pandemic, but the trends really persist. The darker shaded areas reflect higher cases, and you can see these are clustered in the south and west sides of the city, which are predominantly comprised of Black and Hispanic communities. When we look at death by zip code, these discrepancies are even more stark, with more clustering, more light areas seen in those regions of the cities that are predominantly white, and more death clustered in areas where many diverse populations live. When risk scores for severe infection with coronavirus are looked at, these also cluster in those same communities. So what this reflects is that there's underlying chronic disease rates that put populations at higher risk for severe infection with coronavirus. These areas also map onto regions of higher social vulnerability. So the social vulnerability index takes into account both resources and potential disadvantages at a neighborhood or community level. It reflects community capacity, areas of economic disadvantage, higher rates of discrimination, and spatial exclusion from where resources exist are going to be higher on the social vulnerability index. And we see these also cluster to areas of south and west in the city, matching up with the impact of COVID, both in terms of its incidence and death rate. Moreover, when we look at those rates of disease incidence and death and compare it to how diverse individuals have engaged in both treatment as well as vaccine studies for COVID, we see stark disparities. So on this chart, I've gathered information from a number of sources, but to group here the COVID case rate and in the dark blue bars, and mortality rate in the light blue bars, those are to the left of each race ethnicity group. And then to the right of that are bars reflecting the rates of participation in the remdesivir trials, both the preliminary trial as well as the 5 and 10 day trials, and then the Pfizer and Moderna vaccine trials, based on the data that the companies themselves have released related to participation of different race ethnicity groups. So you can see that among the Native Hawaiian, Pacific Islander, and Asian and indigenous populations, American Indian and Alaska Natives, we have virtually no participation in research, either for treatment or for vaccines. The Hispanic Latino population was not, the data was not available for the 5 and 10 day remdesivir trial. There was relatively good representation in the preliminary remdesivir trial, and then mixed representation, but some underrepresentation, at least in the Pfizer trial. Blacks were underrepresented in almost all of the trials, with the exception of the initial remdesivir trial. Non-Hispanic whites were overrepresented across the board, and Asian Americans were relatively proportionately represented, at least in the remdesivir trials, but underrepresented in the 2 vaccine trials as well. And these were despite active conversations, as well as attempts to improve the diversity of participants in the vaccine trials. And I think just demonstrating that we have a lot of work still to do. This is also problematic from the standpoint of mitigating responses to coronavirus, because some of the same groups that are underrepresented in research, where the research could demonstrate effectiveness for their group from the vaccines, these are the same groups that are more hesitant and want to wait and see what's going to happen even after a vaccine is available. Moreover, those who are hesitant might be reassured in some way if research demonstrated safety and efficacy within their group, because some of the reasons for hesitancy include worry about side effects, the fact that they might get COVID from the vaccine, and that these worries might be mitigated if there were higher rates of participation and the rates of side effects were low, and it was demonstrated that people didn't get higher rates of COVID following the vaccine. Other worries for vaccine hesitancy stem a lot from more structural and systemic problems, bringing us back to thinking about how to implement notions of justice and removal of these structural barriers. So coming back to this, this diagram, justice really requires fixing the system so that there's equal access and opportunity. And this means removing conceptions and barriers at a systematic level that don't allow people to participate who might otherwise. I think that any talk that is addressing disparities in participation by diverse groups would be incomplete without commenting on both the history of concerns within diverse populations for research violations and other violations in the past, and then also reframing the discussion as one of breaches of trust. So thinking about our language, understanding and approaches to engendering trust and embodying trustworthiness, rejecting the notion that distrust is a problem within a particular person or group, but that we need to really restore the lack of trust that has resulted from what history teaches us. What are mechanisms to do this? Well, I alluded to the notion of really being particular about informed consent, thinking about what is understood and appreciated, making that process and the entire research process with maximum transparency, not only about individual level concerns about risk and benefit, but also about these notions of research being for social value and not necessarily for individual gain, and the concept of solidarity underlying research and public health, and really introducing these concepts as important ones. Thinking about post-trial access to trial interventions and coverage for medical care, since these are articulated concerns. Reconceptualizing trust in the context of fiduciary relationships, so recognizing that there is a power differential, whether it's physician to patient or researcher to participant, but that there are fiduciary responsibilities within those relationships to maintain trust. Thinking about trust as confidence and competence, so going back to thinking about some of the reasons for hesitancy or for not participating being related to concerns about side effects or becoming ill or harmed as a result of participation, and really needing to reflect competence and where knowledge and where the boundaries of knowledge are. And then perceptions of institutional trustworthiness or program trustworthiness within research, and how we need to sort of think about our research frameworks and programs from the concept of engendering trust. A second main area to thinking about systemic barriers is really more empirical and data-driven, but also requires, I think, attention to knowledge of the history of abuses really within the research community. And this is that I think we need a better understanding of individual and population level social determinants and influencers in research and research outcomes for which race often acts as a proxy. And I really think that we need to systematically start collecting this as part of research protocols. Systematic collection of this kind of information, however, may uncover or ask people questions about sensitive information and maybe frankly traumatic for some, and it really requires this contextualized knowledge of the history of breached trust and competence among research teams to approach screening for these factors with trauma-informed approaches. And I started with the words of Martin Luther King, and I want to close with these words of another person who's become a very prominent and inspiring, as she rightfully should be, figure in the community, whose words really take me a bit back to Martin Luther King Jr.'s sentiment. In The Hill We Rise, Amanda Gorman spoke that we're striving to form a union with purpose to compose a country committed to all cultures, colors, characters, and conditions of man. And so we lift our gazes not to what stands between us, but what stands before us. And I would argue that the challenge before all of us is really to follow that challenge that King raised in 1966 to raise the conscience of the nation to address injustice. Half a century after that speech, we find ourselves grappling with some of the same social injustices and inequities that threaten health at the individual and population or public health levels, and really embracing and implementing strategies that respect ethical concepts of justice and solidarity can move us up the hill that Amanda Gorman has us climbing. I'll leave you with her words, and we'll now be happy to take any questions or comments.
Thank you so much, Erin. That was an amazing talk. There are a couple of questions that I'm just going to go through, a couple of really nice questions to address. The first one is from Megan Carney, who asks, if industry-sponsored research is not often in and of itself prone to seek diversity and inclusion, how do IRBs and local investigators weigh the value of research for some versus the value of research being more inclusive?
I think that is a great question. I would respond to that in a couple of ways. One, I would say that local concerns are always a part of an IRB's discretion in whether or not to permit industry-sponsored research to take place within an institution. And while I recognize that the value that and need to partner with industries who sponsor research, I think that the same way institutions have made statements on a general level about responses to racism, intolerance of certain practice, and reflection of certain values, as IRBs, we have the same obligations to really take a stand with respect to research that has the potential to be so exclusionary of diverse populations that it really perpetuates systemic imbalances. So I think for extreme cases, I would say that really IRBs just need to exercise their discretion in whether those studies would be approved. I think more broadly, fostering partnerships between institutions, academic institutions in which industry-sponsored research might exist, and industry to really share knowledge and best practices about improving diversity across research, including industry-sponsored studies, will turn the wheel over time. It will be a slower approach, but I think a necessary partnered approach.
Great. I think there's actually a couple of other questions about IRB, so I'll just ask this one. You mentioned taking into account their preference for information delivery, such as visual materials. How do you balance this with the additional burden of IRB requirements for approval of such materials, especially on a large scale? How would you decide whether this extra work is worth it versus simply delivering such information verbally? I'm speaking of information not included in the consent form.
Right. I think that's a great question. And I think that's where the concept of using sort of an adaptive approach could be helpful, so that you have, let's just give an example, you have your enrollment targets and you're aiming, if this is a study that might impact the general population, you're aiming for proportionate representation to the general population. You may start out with your the least burdensome approach to the study team. But that an adaptive approach would require you to track whether that is effectively recruiting the population that you're looking, the overall distribution of the population you're looking to recruit. And if it's not, adapting your strategy in some way, shape, or form. That may be introduction of video-based materials or written materials that are more easily accessible or available in different languages. And so that you wouldn't necessarily implement all of these strategies at once, but you would, the goal would be for continual reassessment and then adjustment of your strategy based on the ultimate outcome of trying to ensure proportionate representation. And it may require additional work for IRBs, but you know, I think ultimately we have to keep in mind that if we take the road of highest efficiency, it will sometimes perpetuate the barriers that already exist, and the extra effort is warranted when those become a block to achieving the outcome of proportionate representation that you're looking for.
Great. And then I think we have,
I'll just say one last thing. Some of it may depend on study complexity. So I'm not advocating that in every study this would need to be done, but in studies where those alternative modes may improve participation, that they be considered.
Great. I think that we have time maybe for one more question. This comes from Ariel Egan, who appreciates how you have shifted the frame of mistrust to one of breaches of trust, which lifts the blame off of individuals and applies it rather to the system. I wonder how you see your work expanding to global settings where these systematic imbalances are pervasive and funding may enable such imbalances to continue.
I think that is an excellent question. And again, I would say that I think part of that will require maybe sometimes difficult decisions about whether as investigators in a setting where we are really trying to promote those concepts of trust and trustworthiness, we participate in specific studies in which we know that those breaches of trust are going to continue to occur. And some of it is just taking a hard line, even if it means not engaging in some research that may be fruitful because of the secondary effects of it. The same way, however, I commented about, you know, I think the broader and gentler approach is really to try to help move the needle forward in the global setting as well. And so participating, you know, I've participated in a couple of conversations with visiting individuals who are learning how to set up research ethics infrastructures in the global community where they just are either non-existent or are prone to systemic or government level violations, as well as educating investigators. So not only from the standpoint of research ethics committees like IRBs, but also from the standpoint of investigators. I think we have an obligation where we can to be part of that education, to bring equally to the concepts of respect for individual decision-making and consent, which I think has grown in the global context, thoughts about trustworthiness and justice as fundamental components of research. Interestingly, I do think the concepts of social value and solidarity are often more broadly embraced by the global community than they may be in the United States. And so I think there's a nice opportunity for crosstalk of values and just maybe reframing them in the research context.
Wonderful. Well, we are at the top of the hour. Erin, Dr. Paquette, I want to thank you so much for this incredibly interesting and important presentation. So thank you. And thanks to everyone for your participation and great questions. And look out for information about upcoming seminars. Thanks, everyone.
Thank you, everyone.